Dear friends, welcome to post-lunch session. This is a session which we can't afford to sleep because X-ray is close to your heart. And I have got wonderful panelists with me. Hamara senior bhai, Dr. Naveen, Dr. Samir, Dr. Charul and Dr. Pushkar. So they have been introduced and let me get straight away into should we do chest X-ray? Actually, chest X-ray is good. We should not tell, we should not do. And we keep telling don't do, but we do when it is not required. That is the problem. We just do chest X-ray because anyway, let me confirm what I have examined. I have done chest X-ray when I can't examine. I have done chest X-ray when I don't want to examine. I have done chest X-rays when I want to clear my OPD. I have done chest X-rays to all headache mothers. And sometime when you don't know the diagnosis, parents tell me, sir, ek X-ray karke dekho. So what has happened is, by all these X-rays come to me, and then I have to interpret. Now I am falling in the pit. Because the logic of ordering was wrong, then some interpretation has to be forced in. This is same as your Vidal test, which said both enteric and non-enteric. What are the limitations of chest X-ray in office practice? Please remember, this is a low resolution 2-dimensional image of a 3-dimensional chest. I have done in one line. This is like using a very bad camera and asking a very good photograph. While the good camera is a CT, but it is too expensive and not worth doing in every case. Are we understanding the logic of the CT versus chest X-ray while both have got X-rays as a principal exposure? There is inter-observer variability in the chest X-rays. No two pediatricians agree on the same X-ray. A pediatrician and a radiologist don't agree unless they are husband and wife. There is lot of overlap of radiological findings with other conditions. For some it is TB, non-TB. No, this looks like a mass for me. And I see some of the pediatricians, they put the X-rays like this and see the ward through that window, through that. Doesn't make any sense on the bedside. And also, I see some pediatricians put it on the screen and they go close to the and see if the X-ray can speak something that they can hear. X-rays are not going to solve your problems. These are our problems, not the problem of the chest X-ray. It cannot distinguish between viral and bacterial pneumonia. So those of you who heard for 4 hours in the morning can relax now after the lunch that you can unlearn what you have learned in the past 4 hours. Because the typical viral pneumonia, Abhay Shah only showed next day it turned out to be staphylococcal pneumonia. Did you understand the point? So therefore, don't go on doing the X-rays. And radiological changes are anatomical changes and they lag behind the physiology, which was my first session. The most important, none of the X-rays give you hypoxia. No X-ray will tell you this child is going to die more than the other child. No X-ray is going to tell you that this child should be admitted or not admitted. No X-rays will tell you, yes, I can give antibiotics. What are the recommendations? WHO says that use clinical science. I'm sorry, I'm not a WHO representative, nor they have found. Some of you might be asking, did WHO give you some money to tell all these things? Nothing. In resource-limited countries like us, you should use your clinical science, which is the most cost-effective tool. Chest X-ray is reserved for non-responders, severe cases, atypical cases, cases with recurrent problems where there can be a structural answer to your problem. Are we getting the correct message? American Academy of Pediatrics also says that affording country also says judiciously use the X-rays when you suspect complications or when there are atypical presentations. In spite of all this, we are like children. Tell a child not to eat ice cream, it will eat ice cream. Don't eat chocolates, it will eat the chocolate. You tell the pediatricians not to do chest X, they will start doing more chest X. That's because of widespread availability, low cost. It's there is some sense. A movie cannot be hit without any logic. A song won't be a popular song without any music. You understand? There is some sense like consolidation, effusion, ear bronchogram, all these things are available. Guidance for management. But I have been doing from past 30 years CBC. Has any of your CBCs helped you in practice? Please, any one of you, please speak loudly. When you want the leukocyte count, don't go up. When you want chest X-ray, it will not produce the shadows. Same problem is there here. So in one slide, I'll finish today's session, after which I'll go, when I get into problems only, I'll go to panelist. This is all about chest X-rays in pneumonia. You can see some consolidation, you can see some air bronchogram, you can see some pleural effusion, you can see diffuse interstitial infiltrates or peribronchial coughing, which is very characteristic of viral infections. You can see hyperinflation and patchy opacities. This is done. Today's session is done. Now only we will have some entertainment following this from the panelists. Now, Dr. Charul, I have put two chest X-ray 1 and 2. X-ray 1 is I will give the diagnosis, I will not put them in trouble. X-ray 1 is a normal thymus and X-ray 2 is pneumonia. Tell us why.
So at the outset, I thank my dear organizers for including me with the panel of stalwarts, international sir. Normal thymus is a opacity which is uniformly dense as compared to pneumonia. But pneumonia, the opacity is more denser as compared to thymus. As well as we may also see air bronchogram, and the area of lobar consolidation, it's delineated, while thymus may take any shape because it is a very soft and spongy tissue. It may take any space available in the pulmonary area.
Fantastic. So, excellent version. Thymus is not non-uniform. And pneumonia can be non-uniform. And thymus will never displace any intrathoracic structures.
Sir, can I add one?
Passively bunch of grapes that sit on the chest. Okay. You should know that the thymus is not uniform across the ages. A 2-month-old baby with thymus is not same as 7-month-old baby with thymus, a 16-year-old patient with thymus. So they are all different. There is going to be involution, and you should have some age specific idea about thymus. Now I'll go to Dr. Pushkar. I have given X-ray 1 and 2, and today is pneumonia session. Which one of these two chest X-rays have got pneumonia?
Okay, so my first visual impression would be that the X-ray number 2 tends to appear more whiter, but if we look closely, it is actually an expiratory film. So, like if we were to count the number of ribs, 1, 2, 3, 4, I don't think even the fifth rib is even coming there. So the second film is actually an expiratory film. So I think reading that plate as pneumonia would be very difficult. If we come to the plate number 1, which is pretty hypertranslucent, but then definitely there are some shadows in the right parahilar area, in the right lower zone. So to me, that appears to be probably pneumonia if it agrees with my history. Maybe if the child is febrile, maybe if the child is tachypnic, then I would call number 1 as pneumonia. But number 2 probably is an expiratory film. So this is the reason it is appearing like this.
Yeah. Reading an X-ray and then interpreting is same as looking at a photograph of a girl and deciding whether I should marry or not. When you really look at the patient, it could be totally different. And therefore, you should know which view has been taken, in which phase of respiration it has been taken. Excellent point from Dr. Pushkar. Give him a clap. He did not diagnose that as pneumonia. And somewhere you wanted to give antibiotic, you would try to find something in the X-ray to give antibiotics. That should not be done. And this Film number 1 is a PA and film number 2 is an AP and anteroposterior. And why that happens is because children can't do that PA maneuver. It is very difficult. No child will cooperate. And therefore, most of the X-rays which you take below 4 years of age and most of the X-rays which are portable are AP views, and they are not the nice teaching X-rays that we put in conferences. Please remember this. सर आप इतना एक्सरे सिखाते हो फिर भी मेरे को एक्सरे में प्रॉब्लम है, and that can continue because not because of the teaching problem, it is because of the technique problem. Okay, I'll go to the next scenario. Naveen bhai, which of these two children, X-ray number 1 and 2, have perihilar pneumonia?
Okay, so first of all, thanks to the Chetan and Unmesh for inviting me. I wanted to come and meet everyone, so they were very supportive in accommodating me in this panel and also reminding me I continue to be pediatrician. I have not attended any clinical session for like this for I don't know how many years, and thanks to connecting me with Subramaniam after 17 years. When I was president of IAP, he was executive board member. He has changed a lot, and me also, but
So you are telling you are X-ray number 1 and I am X-ray number 2.
So let me first go to X-ray number 2. It looks like rotation, and very, it's not giving wrong impression. Coming to X-ray number 1, where you have very clearly marked for me, thanks, that looks like pneumonia. But whenever we are talking about parahilar shadows, we must be very careful. If we have started antibiotic, not getting response and not jumping to all those fancy panels and everything, changing antibiotic, before we must keep in mind there may be something else. Mass, anything, and
Anything.
Subbu will tell it more. So that's the key message that one, pneumonia, yes, maybe, but keep other possibility before jumping into other conclusion. And second, two is very, very misguiding.
I think Naveen bhai, all of us agree that you are not forgotten so much as you would claim. Wonderfully being explained. And X-ray number 2, let me start with you. Just look at my hands. These two are the hilum. And if I rotate, one of them becomes more prominent. And that is diagnosed as perihilar pneumonia. Please be careful. This is one thing. And after ceftriaxone, you have to just change and say that it is cured. Please don't do that. It worked. Number 1, the first X-ray, whenever you find a shadow close to the hilum, close to the spine, close to the heart, what I would say close to the core, pneumonia may be a possibility, but there could be some structural disease which we miss because there is esophagus, there is mediastinum, there are skeletal structures, paravertebral masses. Did you understand the point? So in the core, if you get any white shadow, be careful. If at the periphery, if you get any shadow, confidently treat. With whichever antibiotic which Abhaisha agrees or doesn't agree, doesn't matter. Somehow they melt. The point which I wanted to tell you is that please remember when you are in the core, tracheoesophageal fistula, so many things we have seen, esophageal duplication cyst. Did you understand? They are all coming closer to the center. Is this a simple message for you? You will be very careful. When further away, if you have a shadow, unlikely that some esophagus goes to the periphery and comes back to the center. Correct? Right. This, Dr. Samir, this is for you. 13-year-old with fever for evaluation. I will give the X-ray number 1 and X-ray number 2 now for your ease. Is pneumonia there or not there?
First of all, sir, thanks to the
The
organizer.
X-rays are from the same patient.
Thanks for the organizer to give this opportunity to express about what the X-rays. And actually, sir, I slightly differ from you. You are just taking the bread and butter of the radiologist. Okay, the X-ray is not so good, but what we usually see is we have to see the X-ray as whole, rather than focusing on the whether pneumonia is not there, because X-ray will be not give the confirmation whether it is pneumonia or not pneumonia, but considering the whether the quality of how the X-ray quality, and that X-ray quality is not only about the exposure, about the position, which phase of the respiration is taken, and what are the structure actually seen in that thing, that we have to interpret, then and then we can give whether it may be having a, because of this pneumonia can be diagnosed or not diagnosed. We cannot say definitely it is a pneumonia. Part one, what the thing is the overexposure leading to the whiteness, and very difficult for see to that whether any structure is really able to see or not. The second X-ray, that was, if you just closely see, having a double aged sign of that heart is there. That may be showing the left-sided some abnormality is there, maybe because of that pneumonia, or maybe the something related with the collapse.
Fine, fair enough. I think in X-ray too, you get a left lower lobe collapse, which can be missed if you have problems in the exposure. Dr. Samir Bhai was very much correct, and I'll go to the next case. This is a 9-year-old with cough and fever, and what is the diagnosis?
Okay, so I would like to take a pause over here, that even before we jump for the conclusion seeing the X-ray, it is very important to have clinical narrative from the parents. The history is very important. So the duration and chronicity of the cough and fever.
No, history we agreed, because we are given
Yeah.
only 40 minutes.
Because-
We'll get into radiology.
Okay.
Because if I start discussing history, I need extra 5 minutes. Chetan bhai.
Okay, so
हाँ ठीक है. Sir आ गए, ठीक है.
taking into the consideration the
That was on a lighter note.
yeah, the symptoms of fever and cough, I would like to definitely go for chest X-ray, but here the PA view is not showing anything and the patient continues having the symptom. So I would like to order a lateral X-ray, because sometimes a round pneumonia or a developing pneumonia may be missed in the PA view, because in younger children, less than 5 years of age, their anatomy is still evolving, lung anatomy. So the channels of Lambert and Martin and the pores of Kohn, they are not developed. So the collaterals for ventilation, they are not developed. Hence, the pneumonia will appear as a round opacity rather than classical consolidation in the older age group.
Excellent message from Dr. Charul. All that I wanted to tell you from this X-ray is that use the X-ray to rule in, but not rule out pneumonia. Suppose if you would have done only PA view in this child for an evaluation of fever, and if you are not seen carefully, you would have missed that. And therefore, a normal chest X-ray does not rule out a disease. Please remember this. It may not be there, but it may be there, then it could be missed. Okay. This is a nice story of what actually happened in the ward recently in my hospital. 2-year-old was found to have grade 2 murmur, because just before this case came, there was a class on cardiology and lot of banging for PGs. They started picking grade 1, grade 2 murmurs also. And there was some low grade fever, and X-ray 1 was done, and then there was a cardiomegaly. Before the rounds, get a 2D echo done and come back. ECG 2D echo was done. And then I was seeing no murmur, nothing. And X-ray 2 was taken. And Dr. Pushkar, this is an incident that has happened to me. Your thoughts on X-ray 1 and 2?
So both those X-rays belong to the same patient, right?
Same patient.
Okay. So one actually, probably I think the residents were worried about a cardiac disease, because there was grade 2 murmur. And like when you look at this X-ray, like there's a gross impression that probably this is like there's some degree of cardiomegaly. And when you look at like film number 2, which is like really very nicely inflated, and the heart actually does not show any evidence of cardiomegaly, and those markings to me are probably normal if the child has got any viral low grade respiratory maybe an infection going on. Grade 2 murmur is something which we very commonly see, especially even with fever, and 2-year-old kids are also pretty anemic. So unless there was something more, I probably would not have ordered this. but
Yeah.
this is the only thing I have to say.
Fantastic. X-ray 2 was taken only to teach the residents that you better take in an inspiration.
Dr.
So
Subbu,
that
I would
you
like
don't
to add
get it.
one point over here that in the X-ray 1 there is some lateral deviation of the spine. So probably there
Yeah,
is some amount
everything.
of rotation.
Yeah. See, if there is a deviation of the spine, if there's deviation of the X-ray technician also, you will get some problems in the X-rays. So my point was that this is very common in practice. Lots of technical factors will influence the interpretation of the chest X-rays. They don't they don't read textbook of radiology and come. Like we present the images in conferences. In real life situation, they are really difficult and we need interpretation. Now, this is a 14-month-old with cough and wheezing. Are we not doing commonly chest X-rays for this indication? We have got X-ray number 1 and after correcting myself, I did the X-ray number 2. Or you can say I have given the X-ray number 2 as for comparison. X-ray number 2 is the index child with 14-month-old with cough and wheezing. Naveen bhai, aapka comments.
Yeah, so cough and wheezing, and that too in 14 months old is, if there is a really need, otherwise we should not advise X-ray because it's a very difficult to.
Okay, I will add WHO tachypnea for that.
Yeah, so inspiratory film very difficult to take in, and expiratory film will always show this. I think that's also normal and taken in the expiration.
Sir,
So
I
ba-
would like to
Yeah,
add
please,
one
Mata,
point over
please
here because our Nelson textbook of pediatrics mentions that a younger child, like a toddler, if presents with wheeze and cough, we should always suspect staph pneumonia because staph is one bacteria which can present as wheeze in younger infants.
Yeah, fine. The point taken, ma'am. But let me tell you the message is that in an area where there is staphylococcal infection, there you get wheeze and crepitations. It is not that a wheeze will be generalized in a staphylococcal infection. So that is the point. So I'm just correcting. I'm not correcting Nelson, madam. I'm correcting the version. Now, the issue which I am trying to tell here is, whenever there is cough and wheezing, we tend to take chest X-rays. And we try to find a reason for giving antibiotics. And it so happens that a child is having wheeze, it has an outflow obstruction. You ask a child with a wheeze to give a good inspiratory film. I don't know which child from Ahmedabad will cooperate for that. It's impossible. They tend to cry, they tend to be in expiratory phase, and therefore we get into problem. There is one interesting study which said that there is a direct correlation between ordering of X-ray and giving antibiotics. The moment you do an X-ray, you will tell the mother that, yes, I am correct. That's why I am giving antibiotics now. So there is over prescription of antibiotics directly proportional to order of X-rays. So this was an expiratory film. This is a 4-year-old ICU for fever and we do X-rays in the ICU. Samir bhai, this is how we get the X-rays. What to do?
So the
In the
X-ray is
ICU.
taken for the looking for what?
I
That's the
don't know.
important thing. Whether you want to treat or don't want to treat.
No, don't ask me why I have taken this X-ray. These people have taken the X-rays and they have given.
So it is look like a fancy X-ray with so many lines, but difficult to find out any specific etiology with that thing. That it's not solve my problem. My problem is considering when we want to take something really intensively in ICU, it should having a good quality of the X-ray, and now digital X-rays are available with all the resolution to take a proper X-ray with all these proper precautions. Then I can interpret anything. Otherwise, I can't.
Okay, I think Samir bhai wants to take a chest X-ray but doesn't want to interpret. Now that's fine. My question is different. You take an X-ray in the morning, junior resident goes. Then the second, third year will come and say, hey, acha nahi hai, repeat karo. And then the assistant professor comes and check the order one more X-ray. By the time unit chief comes, they want a better X-ray. They'll do one more X-ray. And many pneumonias melt radiologically than because of ceftriaxone. Repeated radiotherapy is given and the child somehow becomes better in ICUs. And the moment X-ray is taken in the ICU, It so happens that you stop looking at the child, whether it goes to cardiogenic shock or anything, they will go on seeing, अरे ये अच्छा नहीं हो रहा है. I will tell you, take Nirma soap, X-ray को धो डालो, rather than treating the child. Because by scratching you can remove that white shadow. If you want to treat the chest X-rays, please stop treating the chest X-rays. ICU is about physiology. It's not anatomy. Number one, you should use ultrasound in the ICUs. X-rays are only for those lines. You know, you have a central line, you want to see where is the tip of catheter, endotracheal tube, etc. But not for anything else. Samir bhai, I liked your version that some digitalization has to happen in the ICU. Our ICUs are very bad. We call them as ICUs. Now, X-ray number 1 and 2, Dr. Charul, both are pneumonias. Are both pneumonias same?
No, they are not same. The film number 1.
Obviously, they are not same.
Yeah.
Now,
But the film number 1 shows inhomogeneous opacity or infiltrates and throughout the entire lung field, except the bases of the lung are clear. While in film number 2, it is situated in the apical area. But what you can see, there is a sharp runoff on the apical part. So probably there is an element of atelectasis or collapse of the lung.
fantastic. The point is very good. There is only, both are upper lobe pneumonias. One is consolidation, the other one is a collapse. The second one is a collapse because of the sharp margin,
And
crowding of
second-
markings. Ha, Samir bhai.
In second, we are just seeing that endotracheal tube also is there. So in second, is that the endotracheal tube is there? That is going on deviated.
That difference is fine for me. But I am asking the right upper zone.
Okay, but because of that, maybe the hypertrophy, we can think for that pneumothorax or something.
Okay, fair enough. The point is taken, but I would say, whatever may be the cause, but there is a collapse. A cause of atelectasis is debatable, but there is an atelectasis or collapse in the second one. And it is not about looking closely to the right upper zone. Look at the mid zone. There is a compensatory hyperinflation. Whereas in X-ray number 1 also the mid zone is there, but there is no compensatory hyperinflation. That tells me about volume loss in the X-ray number 2. Now, Dr. Pushkar, which of the X-ray chest is not a pneumonia? 1 and 2. Both are pneumonias, both are not pneumonias. What do you want to say?
Okay.
I have kept very close X-rays.
So definitely they look white on the right side if you look right upper zone. So if you look at both the upper zones, definitely there is white shadows on both the sides. If you look at the right X-ray, those are very fluffy shadows and very inhomogeneous. So, and also again there is like that white line again that tends to suggest that there is some degree of probably volume loss. And that appears to be probably an intraparenchymal thing to me. If we look at the right X-ray, the right X-ray is very homogeneous. It's a very dense shadow, and it actually, the way just you were saying that अगर कुछ बीच में है, get worried about it, और दूर है तो ज़्यादा चिंता नहीं करो. This is one thing where I'm really not sure कि अंदर से आ रहा है कि नहीं. So I would be really worried about this, and typically I would also look at what is like the tracheal whether the lumen is compressed or not. I look for all those things. I look for whether or not I can see anything maybe in the ribs, maybe if and there is, I don't think any sign of like volume loss in that
Basically,
X-ray.
you wanted to look beyond pneumonia.
Yes, beyond pneumonia,
That's
beyond
fair enough.
pneumonia. I'll
So
speak to
all-
my radiologist or maybe order a CT on this.
So all that I wanted to tell you is that when you get a classical pneumonia diagnosis radiologically, fair enough. But if you have any shadow closer to the core, which I was talking to, like this, for example, X-ray 2, I will not give you the history for want of time. This was a case of neuroblastoma. The idea is it looks like pneumonia. I'm not telling that whenever you get an X-ray like this, diagnose neuroblastoma. That is not the message. The message is that when you get some shadows like this closer to the core, please look at other differential diagnosis and keep them in mind. Okay, I'll go to the next case. It will help. Sir, lateral X-ray, CT, ultrasound, all them will help. But at this stage, I was thinking that be careful. See, it can be pneumonia also, X-ray too. I am not telling it is not pneumonia, just because it was a case of neuroblastoma. But the point is that you should be careful that you can have if it doesn't respond, don't add azithromycin, or let us say from the previous conference, we like doxycycline is better than azithromycin. Don't do that. At least look at the differential diagnosis. Now, Naveen bhai, is this pneumonia or effusion?
Pneumonia.
Pneumonia. The lateral has proved.
Yeah, so yeah, in PA we can see the slight lucency which is more clear in the lateral one, right?
Yeah, I think can you see small lucency there? One is because of the lucency, that means there is some air and probably it is pneumonia, not an effusion. However, if it is an effusion, you also consider possibility of necrotizing pneumonias, etc. They will also look liquefaction in the chest X-rays. But my point is that when you get some shadows like this and when you have a doubt, you should take a lateral or go ahead with ultrasound or CT, which I am going to come little later on. But the point is that when you get some doubts like this, don't put a chest tube immediately or put a synthesis or go ahead. Please have a relook and discuss with radiologist. Dr. Samir bhai, left hemithorax opacification. I am giving you the diagnosis, it is not an effusion, but why it is not an effusion?
One important thing that is what the sir has said, this angle is already seen in this X-ray also. The thing, the costophrenic angle, once it is there, you have to consider it will be other than the pleural effusion, because that may be the opacity. Second important thing, if you just check it out, the whole shadow is shifted toward the right side of the left side of the chest, and that's it. Something going thing. It is a pushing the thing rather than or the pulling that. Either of thing may be possible.
So be careful about diagnosis of.
Sir, I would like to add that
Please.
when we look closer, there is also overcrowding of the ribs on the left side.
Fair enough. So this is not an effusion. What it is, we'll see later. Because if I start discussing each X-rays, it will take time for me. Number 1 and 2, these two are the X-rays, and I am not going to give the history. Between 1 and 2, Dr. Charul,
Yes.
which of them is probably normal and which of them is a viral lower respiratory tract infection?
Looking at the films, the film 1 looks normal. But in film 2, the infiltrates, the bronchovascular markings, they are extending beyond the 2/3 of the lung field. So probably there is an element of interstitial pneumonia over here. So probably the film 2 is having viral LRTI.
Fantastic. So how do you look at the more than 2/3 of the lung fields? See, now if I blur that 2/3 of the lung fields, you will realize that the bronchovascular markings extend beyond 2/3 of the lung field, where you don't need to find a vessel. There if you find a vessel, that means there is increased vascularity. Am I clear to you? In the periphery, the vessel should become thinned out and they should be invisible. If they are visible, that means there is an inflammation. Probably that this report is very common by radiologists. They say increased bronchovascular markings correlate clinically. Then I will always write back to the radiologist telling that this child has fever from past 3 days, correlate radiologically and get back to me. You know, that's how they pass the buck. And it is very, very difficult. There is always a fight or a no fight between radiology and pediatricians for want of understanding of this bronchovascular markings. 3-year-old with mild fever and respiratory distress and wheezing for 2 days, and this was thought to be tachypnea on pneumonia. And so, Dr. Pushkar, your thoughts?
Looking at this, 1, 2, 3, 4, 5, 6, it's adequately inspiration is quite fine. I definitely see, sir, some markings more on the right side as compared to the left, and with these bronchovascular markings probably increased, I actually will think in terms of a viral pneumonia.
You are thinking in terms of viral pneumonia.
I'm thinking in terms of
Fantastic.
viral pneumonia.
When you get X-rays like this, there is a problem. Is the right side increased or left side decreased? You understand this problem happens, and every time I see crepitations will be there on the right side. Baldev, when I order the X-ray, the findings will be on the left side. And in MD exam, we always fail in respiratory only because the side is a problem, then whether it is right or left, our findings are always correct. Now, this was a case of a left-sided foreign body with air trapping, and therefore, here the point is not about how correct we are in diagnosing X-rays. You must pick up unilateral hyperlucency or increase markings on the right side, and then again start correlating clinically and try to find out. Now, Naveen bhai, which is pneumonia, which is an effusion?
Number 1 is effusion. Number 2 is pneumonia.
Pneumonia. And Naveen bhai want to stop there, and he is correct. And I don't think I need to explain this. All of you get the point. Now, number 1 is having a fluid on the left costophrenic angle, which is having same radio density of fluid in the heart. There is a fluid in the heart, but on the left side, the fluid in the heart is not matching the radio density of the pneumonia. Okay, fair enough. Now, I'll quickly go to ultrasound. How many of you do ultrasound? Please raise your hands. I am seeing good number of you. So at least a few people in Ahmedabad are earning. That's because now you see the debate on the vaccine. There is only one thing that you can do is to go to government and give the vaccine for the private practicing pediatrician. There is nothing left. Do you all agree? In pediatric practice, there is no way that you can make money. Obstetricians have made money not by delivering but by doing ultrasound. And IAP has to take it forward to license all the pediatricians that they are legally okay. Chetan bhai, when you become the office bearer, please remember that the pediatrician should also be licensed to do ultrasound. Ultrasound is a very good thing. Now everybody does ultrasound except pediatricians. And we only read that non-specific mesenteric lymphadenitis, we go on scratching our head. You got the point. For every constipated child, I sometimes wonder is the mesenteric lymph node presses the colon and cause constipation. You know, to this extent we get the reports on pain abdomen. Do you all agree on this point? But if we start doing ultrasounds, then we start realizing that there needs a correlation and we will be better. I quickly go through the ultrasound of the chest. Ultrasound of the chest is the simplest thing that you can do. Ultrasound of the chest is all about study of artifacts. This is the only area we don't study naturally. We study the image unnaturally. Absence of an artifact is pathology. Air doesn't allow sonographic waves to go in, correct no? If it allows, that means there is fluid. There is mass. Have I oversimplified the ultrasound? If you get artifacts, it is normal lung. If you don't get the artifacts, that means it is a diseased lung. So you have A lines which are reflection of the pleura. First thing that reflects is a pleura. And there is a reverberation artifacts. You remember the mirage in the summer? You know, you get those waves. Something like that, you get A waves. And second is you get B lines, which are same as fluid in the septa. Septa, acini, interlobar, that fluid will give rise to B line. The B line is that longitudinal lines, whereas A lines are horizontal lines. Don't get confused, start doing, you will earn both knowledge and money. But my point that I wanted to tell is you can get consolidations, air bronchograms also in ultrasound, but this air bronchogram is reverse of chest X-ray. Here the air is seen as white in an ultrasound because it reflects, and fluid is seen as black. Whereas in an X-ray or a CT, air is seen as black and the consolidation of fluid is seen as white. Did you understand? Just reverse the findings. It is excellent for fluid detection, and you can see the pleural effusion. You can also see the septations better than CT, because CT is section images. If the septa is thinner than the sections that CT can take, you can miss the septum, but in ultrasound you don't miss them. It is the artifacts that speak to us. You have seashore sign and all this. Those of you are more interested, please come to my institute. In 2 days I will make you sonologist, provided you will give me 10% commission after getting trained. These are some of the sonographic images this is only sensitizing session, and therefore I just need another 2 or 3 minutes to wrap up. Can I take this? Yeah. What are the advantages of ultrasound over chest X-ray, Samir bhai?
First and the most important thing, there is no radiation. That is one of important thing. Second thing, it will be really require a good quality personnel and the instrument, and that will be give us so many problematic things not able to identify in the X-ray, that we can easily identify with the X-ray with a good expertise. Important thing will be, it will be really require immediately on bedside. It can be possible immediately. Some important thing is कि many things which will be not possible to check into the any different possibility of the X-ray size, lateral view or the front view, whatever the thing, it will be easily possible for the USG to take it out, and it's not so costly also. That's an important thing. So
Fantastic. So you can also charge some. Okay. And you can keep repeating, and mothers don't question you, why did you repeat USG? But she will always ask you, why did you repeat chest X-ray? Okay, let me, for want of time, do not go for panel discussion on CT. I will browse through the CT. CT scan give you ground glass opacity, consolidation, reticulation, ectasia. It can give rise to information on complications of bacterial pneumonia. When you want to study pleura, you do ultrasound. When you want to study the parenchyma, you do CT chest. That is pretty simple message. These are the CT findings in pneumonia, like air bronchogram. CT scan also give you more information on viral pneumonia. You know from the past COVIDology that you have all gone through, lot of scoring, this, that, etc. CT only problem which I found from the practicing pediatricians is that don't order HRCT for everything. Please order a CT, discuss with a radiologist. HRCT will give you only the image at a section. It's like a piece of bread. It is not going to tell you about complete bundle that is there, so you need a volumetric CT. Last my messages. Make a clinical diagnosis before ordering either chest X-ray, ultrasound or a CT scan. You have got 3 radiological options for you. Don't equate a radiological finding for a radiological diagnosis. You find a consolidation, you find a white patch, that is a radiological finding. There is a radiological diagnosis which you have to make. Did you understand? So you see some shadow, the other side is normal, cardia is normal, chest is normal, hemidiaphragm is normal, thorax is normal, like that. You should make complete evaluation, that is called as radiological diagnosis. You should make a clinical diagnosis, should make a radiological diagnosis. You must do clinico-radiological correlation. It also holds true for laboratory discussion that has happened. Unless you correlate, it never makes a sense. And ultimately, you should revisit your clinical diagnosis and confirm your clinical diagnosis. Don't start your treatment with a radiological diagnosis, which often we do. Do you all agree on this point? That's the point. You should come back to clinical and make a diagnosis. Don't you think so? Shades of grey are beautiful. And a good clinician need not be a good radiologist. It's not necessary. But if you are a good pediatrician and if you really want to make money, either learn ultrasound or marry a gynecologist or a radiologist. Thank you very much. And I thank all my panelists for being so nice and so informative, so crisp and clear in 40 minutes. Thank you very much.
It was wonderful discussion.